preserve our vision. Where lions, Leos, family, and friends meet, be present, Lord, to weld our hearts in one accord. To do thy will, Lord, make us strong, to aid the weak and right the wrong. All these things we ask in your mighty name, Jesus Christ. Amen.
Amen. Thank you, Lion Denisa. I am Lion Allison Bishop, the Vision Committee Chairperson for this year for the District 60B. And I would like to say good evening to all Lions, Leos, and all our guests. Please excuse me, my camera does not seem to be working. I'm having some technical difficulties with the camera, so please excuse me. I would like to say thank you again for taking the time this evening to join us. This, as you may know, is Glaucoma Week from March 10th to 16th. So this is the last day of Glaucoma Week. Glaucoma can be a very scary disease, in that by the time you realize that you have it, you may already have advanced glaucoma and you may already have lost quite a bit of your sight. So this evening, we will learn much about glaucoma, and we have a distinguished panel of persons who will speak to us and help us to learn more about glaucoma. I would like to invite our esteemed District Governor, Lion Dr. Carlisle Goddard, to bring his remarks. Lion District Governor.
Madam Chairperson, members of the distinguished panel, Lion leaders, Leo leaders, my fellow Lions, my fellow Leos, guests, good evening. Indeed, it's a pleasure for me to bring you greetings at this meeting. And we know that vision and vision-related illnesses is a significant tenet amongst Lions and Lions Club International. We were challenged to become the night of the blind, and we've accepted that challenge. And so when we now become more pointed and focused on the Caribbean, where cataract, glaucoma are the major causes of blindness and visual-related illnesses in the Caribbean, it is only fitting that we should, in our niche, point out the things that matters most to us. So I'm very grateful to know that this panel has come up with a concept to discuss glaucoma, which is very important to us in the Caribbean, more so because one, we're Black, two, we're an aging community, and as we age, cataract and glaucoma incidents are increasing. So I hope this panel can enlighten us more onto the way forward. We know that glaucoma will be an age-related factor, and since we can't change age, can we change something else in our environment that might slow down the onset of glaucoma? We know there's a genetic heritage. We cannot change that, but we can do other lifestyle-related things that look after our general health that prevent the genes from turning on. So I hope we find this conversation exciting and stimulating to the point where we can move forward from this discussion to bring about change in our local community, knowing that vision matters. Most people would prefer to lose a finger or a toe before they lose their eye. And that's very relevant because seeing is one of the few senses that we cannot replace with all our technology. So I'm glad that we can entertain a discussion, an open discussion on glaucoma and its consequences. So to the team, I thank you for coming to the topic. To the panelists, I look forward to engaging with you in this conversation. Have a wonderful evening and a wonderful conference. Thank you.
Thank you very much, District Governor. I now invite team member Lion Jillian to introduce our guest speaker. Lion Jillian. Your mic is muted, Lion Jillian.
Good evening, everyone. Dr. Kiowa Clark is an ophthalmologist with special interest in glaucoma. He graduated from the University of the West Indies with a Doctor of Medicine in Ophthalmology. Dr. Clark is also a Fellow of the Royal College of Ophthalmologists, London, and the International Council of Ophthalmology. He hopes to use his expertise to help prevent avoidable blindness through public education and awareness. Welcome, Dr. Clark.
Hi, thank you. Thank you for having me. I'm glad to see Dr. Goddard here. I know he doesn't remember me, but I've sat in his classes before. Very good introduction. Okay, so welcome again to the end of World Glaucoma Week. And I was asked to give a little educational talk on glaucoma. Some of the basics, something that will help us, as Dr. Goddard emphasized, try to reduce the incidence of blindness associated with glaucoma. Okay, so what is glaucoma, right? I mean, we knock this word and name around quite frequently, and many people don't actually know what it is. They definitely know it's associated with blindness, but they're not sure exactly how or what it is. So glaucoma is actually a complicated, chronic, progressive group of diseases. It's not just one, which leads to a common endpoint, which is loss of vision. And that loss of vision is through optic nerve damage. And it's usually, but not always, related to high pressures in the eye. And these pressures are not related to the blood pressure. This is separate and apart. And it can affect anyone. And it's quite common in our society, as it's one of the legacies of the Atlantic slave trade. And the gene, which is associated with glaucoma, or the genetics associated with glaucoma, came across and is extensive in the Caribbean. It's commonly referred to as the silent thief of sight. So everybody here is going to enroll in medical school now and get a short anatomy session about the eye, because you have to kind of understand what is in the eye to understand how glaucoma works. So essentially, the lower diagram is a diagram of the eye cut in half. And the front part of the eye is the cornea. The lens is in the intermediate part. And between the lens and the cornea, there is a watery fluid, which we call aqueous, which is important in glaucoma. To the back of the eye, in this area here, is the jelly of the eye, which we call the vitreous. And then the important film, which collects the light energy and converts it to the signals to allow us to see, is the retina. And that sends those signals down to our optic nerve, which sends those signals onto the brain for us to perceive our environment, right? Now, all of these things have to be working for you to have vision, but glaucoma particularly affects the optic nerve. So how does this happen? Well, as I said, it's commonly related to high pressures in the eye. And this pressure, for some reason, is transmitted to the optic nerve and causes damage. Exactly how that happens, we don't actually know. And why it happens, we don't actually know. But we do know that when we reduce the pressure, it helps protect the optic nerve. And when this optic nerve is damaged, it affects our field of vision. It's the area that we can see around us. And as you can see in the images here, as glaucoma affects the nerve, the field of vision on the outside, or the peripheral vision, is what is affected first, and it gradually encroaches on the center. And this field of vision loss correlates to what we see when we examine you at the slit lamp, which is what the optic nerve looks like when we're taking a look in the eye. And this is a normal, healthy optic nerve on the left. And as you can see, this one is all white, and this little round area, which we call the cup, is very, very big. And that signifies pretty bad glaucoma damage. All right. So who gets glaucoma? Well, Dr. Goddard kind of alluded to the fact that we have it quite prevalent in our Caribbean population. And as I said before, it's a legacy of the African slave trade. So people of African descent tend to have higher incidence and prevalence of glaucoma, and populations with high proportion of African descendants similarly do. Family history, because this is likely related to our genes and our genetics. Family history is important because this is where our genes are passed on. So people with a significant family history, especially one of a first-degree relative, so that's mother, father, brother, sister, children, having glaucoma or going blind, that is significant. High pressures, as I mentioned, not everybody has high pressures in the eye and that have glaucoma, but the higher the pressure, the higher the probability of progressing on to glaucoma. The nerves. Some people who have nerves that are predisposed to damage. Thin cornea, which was that structure to the front of the eye that I mentioned. People who have thin corneas are at an increased risk of glaucoma damage or seem to appear to have more aggressive forms of glaucoma. Age is definitely a factor. It's not very common for us to see glaucoma in children, but in our population, definitely in the age 35 and above is where the incidence starts to rise. And as we get older, the pressure in our eyes gets higher, so it's automatically linked. And definitely in our 50, 60, and 70 age group, that's when we have our highest incidence of glaucoma. And then there are other secondary or other causes of glaucoma, like steroid use, which can cause the pressures in the eyes to go up, and trauma, which can damage the drainage channels that are required for the fluid to drain from the eye and cause high pressures in the eye. These can all contribute to glaucoma risk. Then there are minor risk factors, such as diabetes and high blood pressure. People with migraine seem to be predisposed to getting optic nerve damage, and it's likely because there's a similar facility of blood flow going to the linings of the brain can be affected, causing migraine, and similarly, it can be affect the blood flow to the optic nerve. Heart disease and people who are nearsighted, people who are nearsighted or myopic, they tend to get a certain type of glaucoma, usually primary open angle glaucoma. And then people who are farsighted, who tend to have shorter eyes, tend to get a different type of glaucoma called angle closure glaucoma. So how do you know if you have glaucoma? Well, as we said, it's commonly called the silent thief of sight. So many people won't actually know until it starts to really affect the vision and encroach on the central vision. So it's really pretty much asymptomatic or has no symptoms until late stage disease. That being said, there are some people who will present with symptoms, and some of those symptoms might be headache, pain, cloudiness of the vision suddenly, seeing halos when you look at the lights, everything looks hazy, and that can be a sign of an acute attack of glaucoma. So since it has no general symptoms or signs, you don't feel anything until advanced disease, it's actually suggested that you get very regular examinations to ensure that you may not have glaucoma, especially if you have a family history. So if you're younger than 40 years old, you should have an eye check minimum of every 4 years until you reach 40 to 55, at least every 3 years, 55 to 65, at least every 2 years. Once you're older than 65, yearly, right? And that is the maximum. You can obviously go more often if you so choose, right? And definitely with any of those major risk factors that we talked about, family history or having had trauma, steroid use, you should probably get your eyes checked yearly after the age of 35. Some people even advocate after 21 in our population. So when you actually go to have these tests done and seen by the ophthalmologist or the optometrist, the primary eye care provider, what will we do? So we're going to check the pressures, because pressures are commonly associated, high pressures are commonly associated with glaucoma. And we can do that by many means, which we'll talk about later. We're going to check your optic nerves, because we can actually see nerves that look suspicious for damage, or actually tell if there's advanced damage once we see the optic nerves. Then we're going to check the function of the nerve by looking at your visual field. And we do that with a special machine where we can flash some lights around. So you can press the lights and we can see if there are any areas missing in your vision. We also check what's called the angle, where the cornea and the iris meet. And that's where the natural drainage channels are. And we can sometimes see if those drainage channels are blocked. Majority of patients, no, they're not blocked. But in a few cases, they are blocked and can be dealt with. We check the thickness of the cornea, because that also stratifies your risk, not only of having glaucoma, but your risk of progression. And then we take pictures, because that's how we follow glaucoma. We need to look at what it was before and look at how it is after, so that we can look for progression. So measuring the pressure, just in case any of you are afraid, it's painless, okay? There are many ways we can do it. Some of them which require us to touch the eye or contact methods, and then some that we don't have to touch the eye. And I'm pretty sure most of us have gone to the optometrist and have that a horrible puff of air in our eye to detect the pressure. Then we can check the nerve. Most of us will use the slit lamp, as you would see in most ophthalmologist offices, but there are other methods to use, like cameras and small devices, as seen here, where the medical students are using on the picture in the upper left. And what we're looking for is the images below to see if there's healthy optic nerves or unhealthy optic nerves. And then visual field tests. This is probably the most horrible test you'll ever take in your life. It's harder than common entrance, right? And essentially what it is you have to place your chin in the machine, and we're just gonna flash some lights while you look straight ahead. And you have to press a button when we flash your lights. It's ideally done in the early morning because that's when you're most awake. I can admit myself has fallen asleep in one of these machines before, and I'm sure anybody else who has done the test can attest to that. So it's very important that when you actually get an appointment to do these tests, you don't have anything else to do. It's not a late night before, so that you can have as much concentration power as possible to get this test done accurately. And then when you do the test, it gives us a printout, something like this. So this is essentially a normal visual field test. And what we're really looking for is dark spots. So like this spot here on this left eye visual field test. But this spot is actually normal. Everyone has this. This is your physiological blind spot. This is why you can't see cars sometimes coming out on your side mirror or somebody coming past you on the side of your vision. So this is normal, but we would be looking for other dark spots that may be within this field, especially if they're coming close to this very central area, which is very important for you to be able to fixate and look at something, right? And this is not a test that is done one-off. It has to be done serially, maybe every 3 months, initially every 6 months, or yearly, because the hallmark of glaucoma is progression. It is something that gets worse with time. So this test actually has to be repeated so that we can follow it closely to ensure that it's not worsening. There are other tests as well that we can do. This is another example of the field test with glaucomatous nerves, and it gives you an idea as to the level of visual impairment you can get. So in people with early glaucoma, which is the ideal time to detect glaucoma, if you do have it, you can see here in the bottom left image that there's minimal changes in the vision. Yes, there's some darkening at the very, very edges, but this person probably could drive. They can see everybody crossing in front of them. They can see everything around them. They're probably safe for this person to drive. But as glaucoma gets worse, this vision, this darkness encroaches slowly on your central vision. So you can imagine someone driving with moderate or severe glaucoma, they won't be able to see people crossing the street in front of them, or they wouldn't be able to see cars coming out of side roads. So it'd be very dangerous to drive with that. And it's actually very difficult to maneuver with a very small pinhole tunnel central vision. I will put it to anybody in here if you want to see how difficult it is to move around. You can cover both your eyes with your hands like this and make as small as possible hole and try to walk around in your room without bumping into anything. And you will see how difficult it is, despite being able to see fully with your central vision, how difficult it is to move around. So another important part of the examination, which you shouldn't be afraid of, because again, it's painless, is for us to check the angles with these very special lenses. And the importance for checking the angles is because sometimes those angles can be blocked up. And that specific type of glaucoma is called angle closure glaucoma. And the treatment required for that type of glaucoma is a little different to the run-of-the-mill open angle glaucoma. As I said, we can measure our corneal thickness. This can be done with contact and non-contact methods. Again, it looks horrible, but it's painless. And then pictures. And pictures can be actual photographs with a camera, as we have seen with these photographs here before, or they can be very special pictures, like with this instrument here called an OCT. Now, this is a very valuable instrument in glaucoma, especially within the last 10 years, because this actual picture will take an image of the retina an optic nerve and magnify it many, many times. And we can actually see changes in the retina, which will precede any changes in your visual field, meaning we can actually detect glaucoma now before you actually lose any vision at all. And then once we've found that you have glaucoma or at risk of glaucoma, we would want to treat it. So what are our treatment options? I'm sure everybody here knows someone on glaucoma drops. This is probably the most common treatment modality that we employ, right? And these drops all are aimed at lowering the pressure in the eye because that's the only risk factor that we can actually change. We can't change your age. We can't change your genetics. Definitely can't change your ethnicity, but we can change your pressures. So everything with regards to glaucoma treatment is about monitoring and lowering pressures in the eyes. Another option as first-line treatment, again, made big moves within the last 5 years, is SLT laser. All right. Now, this is a special laser that we can use to laser the drainage channels in the angles to allow the natural drainage channels to work a little bit better. And in actual fact, you can get that done even before you are started on drops. And some people actually get it done so that they can come off of some of the drops. Now, it doesn't work for everyone. It has about a 78% success rate. And sometimes it has to be repeated. It has about a 2-year, 3-year lifespan. So some people will have to get repeated procedures done. But again, it's very, very low risk. I would almost say it's painless, almost. And people do enjoy the fact that they don't have to take drops and still have generally good pressure control. Now, what if my drops aren't working? Well, the first question you have to ask, are you taking them correctly? I mean, it sounds like a pretty basic question, but there are rules to taking the eye drops. First off, you shouldn't put any 2 different drops in the eye back to back. The eye can only hold 1 drop at a time. So if you put 2 drops in the eye back to back, you'll be washing out the first one and it won't work. The second thing that patients tend to do is that sometimes the drops sting and they'll tend to squeeze the eyes very tight when they put in the drops. And you're actually squeezing the drops off the surface of the eye. And in that instance, they won't work very well. Thirdly, what people tend to do when they take eye drops is they blink a lot. They put in the drops and just blink, 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 blink. And what you're doing is actually blinking the drops down into your natural tear ducts, down into the back of your throat where you taste them. And unfortunately, they're not very effective in the back of your throat. So the ideal way to take the drops is one, if you're taking multiple drops, you space them with a minimum of 5 minutes. When you're placing the drops in the eye, ideally to do it in a lying down position. You put a drop in the eye and you close the eyes lightly, like if you're sleeping, for about 5 minutes. And that's the ideal way to take a drop. Now, if they're taking the drops properly, sometimes, some people, some medication is not effective. And that is the same for glaucoma drops. So if that person is progressing or their pressures are not adequately controlled, then they will probably require some form of surgical intervention, right? And there are different ways, different types of surgeries. Some of them we create alternative passages. Some of them we try to address the natural drainage channels. But everything, again, like the drops and all other glaucoma treatments that we have available to us right now are related to lowering the pressure in the eyes. Make sure whenever you're talking to your doctor, whoever is prescribing a surgical intervention, you discuss possible complications and after surgical care, because that's very important in the success of the surgery. And sometimes after surgery, there's a big benefit. Some people are off all glaucoma drops altogether and they're living life as if they never had glaucoma, right? So some of the surgical options, I was tempted to put in a video, but I then decided not to. I didn't want anybody fainting in the Zoom. So there's minimally invasive glaucoma surgery. And this type of surgery addresses the natural drainage channels, right? So if you look at these two pictures here, these are two examples of a minimally invasive glaucoma surgery. And what we're looking at through this special prism here is the angle. This dark line here is where the fluid drains through. You can see it here as well, all right? And what we're trying to do is create a passage through that, because there's high resistance to try to flow through the tissues to get into that drainage channel. So in this case, this is a dual blade. We can open it, like a slice it open. And in this case, this is called the eye stent inject, where it's a small little grommet, a little hole that you can use. And you can see how tiny those are. They're smaller than the tip of your finger, all right? Or we can forget about your natural drainage channels altogether, and we can create a whole new drainage channel, all right? One method, I'll admit, my favorite method is the trabeculectomy, right? And you can actually see this area here is where the fluid from the inside of the eye is draining. So it creates an area called a bleb, but no worries, no one will usually see that because it's hidden under your upper eyelid. Or we can actually create another channel using a tube, and you can actually see the tip of the tube here, right? And that goes and drains again to the outside of the eye. And by shunting that fluid out of the eye, you can actually lower the pressure significantly. So significant, you can actually have pressures in the single digits, which is really, really good. So outside of that, there are certain frequently asked questions that we get, which I would like to address here before you hit me with all your questions. But some of them Dr. Goddard alluded to, which was lifestyle changes, right? Is there anything I can eat or do that can help me cure glaucoma? But unfortunately, glaucoma is not really like one of those lifestyle diseases. The real aim of glaucoma is not really to stop you from getting it. The aim is prevention of blindness and prevention of visual impairment. So no, we can't actually give you a diet scheme to stop you from getting glaucoma. But with regular eye follow-up and early treatment, you can actually prevent visual impairment from glaucoma in the vast majority of people, right? Marijuana culture has spread like an epidemic throughout the world in this last decade. So everybody's asked about marijuana and glaucoma. And unfortunately, fortunately, yes, it does lower the pressure in the eye. Unfortunately, it doesn't lower it for long enough. And it's still found that people who do use marijuana via whichever means, smoking, drinking, they still have been shown to progress. They even tried to create a drop from the cannabinoids from marijuana called cannasol. And that too wasn't shown to be very, very effective in preventing glaucoma progression. All right. Is there, will I go blind? All right. Majority of patients who actually have glaucoma don't go blind because they're picked up early enough and treatment instilled so that they maintain their vision for the rest of their lives. But it is not to trivialize what glaucoma is. It is a potentially blinding disease. And the vision loss associated with glaucoma is actually irreversible, meaning once it's gone, we can't get it back. So our whole aim is through screening and early intervention to prevent the impairment associated with glaucoma-related visual loss. All right. Driving. Driving is always a question. Yes, people with early glaucoma, as you saw with the earlier slide, should be able to drive. It all depends on the level of visual field loss. And that is something you should discuss with your ophthalmologist to determine whether you have functional enough vision to determine if you are able to drive. How can I help my relative with glaucoma? Well, where help can be afforded to anyone. One, people with blindness tend to be have a stigma associated with it, and as a community and as relatives, we misunderstand that, this is not this. Sometimes this can be avoided, yes, but in that person's case, it may have been unavoidable. So we just need to provide support for those persons, and support can come in many ways. Helping them put in their drops, as simple as that. Sorry. Taking them to their clinic appointments, um, helping them in their day-to-day activities around the house, especially those who are visually impaired, all right, significantly visually impaired. Moving things around the house to make the house much more safe for somebody who's visually impaired, all right? And then advocating for your relatives, especially if you have a family history or someone in the family has a family history of glaucoma, to have very frequent eye checks with their primary eye care provider. And then glaucoma and cataract. What's the difference? People commonly confuse the two. But cataract essentially is a cloudiness of your lens, that structure that was in the intermediate part in anatomy class. And that gets cloudy with age. And what we can do is we can remove it with cataract surgery, and you'll see again. So essentially, cataract is an age-related degeneration. Can't avoid it. Once you have gray hair and arthritis, you have cataracts. But it is a reversible cause of visual impairment, which is important to note. On the other hand, glaucoma is an irreversible cause of visual impairment. So it's much more important for us to pick up and deal with glaucoma early than it is for cataract. That being said, cataract and glaucoma can exist in the same person, right? And they can be dealt with simultaneously or individually. And that is something that you'd have to discuss with your ophthalmologist on what would be the best way forward for you. So I have provided some other resources that anybody who needs to look up a little bit more about glaucoma, or you can ask your primary eye care provider or ophthalmologist to get some more information, and you can hit me with all the questions you like.
Thank you so much, Dr. Clark. A very, very comprehensive presentation. Any questions for Dr. Clark? I know that you're burning to ask some questions. I have a question, Dr. Clark. I am a person. I'm a I'm a technologist as well, and I have done visual fields on persons for many years. And sometimes I will say to a person, well, how did you get here? And they would say, well, I drove. And I'm looking at the visual field and I'm thinking to myself, this person drives, but I don't know what happens. But sometimes I wonder if persons are told you shouldn't drive because they just continue driving and their visual field is saying, well, they shouldn't drive. How do you address that?
Right. So the first thing is sometimes people don't do visual fields very well. Mm-hmm. As I said, it's much harder than the common entrance. So it can be difficult, and they may not have had a good day. But if a repeated visual field test 2-3 times you're getting the same thing, yes, sometimes people don't realize the impact of glaucoma on their overall vision. And the reason for that is because it takes your central vision first. They can still see, they can still read everything on the vision chart that you put in front of them, but they haven't noticed that they have a significant impairment of their peripheral, their side vision, right? So it takes counseling, and some people it takes a lot of counseling for them to understand the risks involved. The major thing is that they don't really understand how much of a deficit they have seeing people coming out of the side of their vision. Because how vision works, it's like a cone. Things close to you, you use a lot of your peripheral vision, but things in the distance, you actually use more of your central vision. People use a lot of their distance vision for driving without using a lot, looking at things close because you're looking down the road. So a lot of people don't actually notice the deficit. So it just takes counseling. Again, it's something to discuss with the ophthalmologist to understand whether or not they're able to drive or not.
Okay, thank you. And also, I also know I have met a couple persons and who said that they were diagnosed with glaucoma and they took the drops, I guess, to the end of the repeats, and then they never took any more and they never went back. Have you gotten that a lot?
Yes, that is a common issue. I mean, remember, glaucoma affects people as more incidents as we get older, all right? And as we get older, sometimes our faculties decrease. Not our intention. So they need those kind of people need a lot of support, both from the ophthalmologist and their immediate family and friends. So yes, they probably just didn't understand the need to repeat the drops. Or there are many other reasons. Many people don't like to take drops. People don't like to take medication in general. One of the ways around that is things like the SLT laser and surgery, where you actually negate the need many times for taking the drops. So people who aren't able to take drops and they're still progressing, or they don't want to take drops and they're still progressing, we do have other options for them.
Thank you. And my final question, I know that glaucoma is irreversible, but there are people out there who have lost a lot of vision due to glaucoma and they still have hope. Is there anything in the future that we can look forward to that may be able to, help that type of patient?
Well, I'm not really a psychic, but the real issue is the optic nerve. So once we figure out to regrow some optic nerves, I'm sure there'll be hope. But until then, we generally our aim is to keep what you have till you leave the earth. Um, I will admit there are some people who come in with very high pressures and horrible vision, and once they get the glaucoma surgery and the pressures drop, the vision brightens up, and they're quite happy. So although we say yes, it's irreversible, some people do get back a little bit vision once they institute treatment. It's not dramatic, but it sometimes it is the difference of not being able to maneuver around your house independently.
Any other questions?
Hi, Dr. Clark.
Yes.
Right. This is Allison's husband, Lairani Payne. Well, I've been diagnosed with glaucoma years and years ago when I was 20. And at that stage, again, I was not aware of how severe and serious glaucoma was. And even before that, the person that I was in their care, they didn't know I had glaucoma, even though they were an ophthalmologist. Some doctors now are telling me that probably he thought I was so young that it's not possible to have glaucoma. So is it a case where now more people are being screened for glaucoma, regardless of their age, no matter how young they are?
That's an excellent question. So the issue, what we're taught in medical school in the books is, glaucoma is a disease of the middle-aged to elderly, right? But we've been seeing, especially with hereditary glaucoma, which is what is most people here, is that especially if you have a significant family history, the subsequent generations actually present younger and younger. So in our population, where we have a high incidence of a high prevalence of glaucoma, it's like around 7%. I mean, that's close to almost 1 in 10. You're seeing people younger and younger showing up with glaucoma, and not just mild glaucoma. People younger showing up with advanced glaucoma. So yes, screening actually is suggested now in our population. Some people suggest 21. Now, granted, if you were picked up in 20, glaucoma is generally a slowly progressive disease. If you started screening by 21, you still should have been picked up early enough to institute treatment. But yes, it is complex. It's sometimes difficult to diagnose glaucoma as well, particularly in young people who may already have suspicious looking nerves, because the hallmark of glaucoma diagnosis is progression. So if you come on one visit, it may be difficult to say. Even at 2-3 visits, it might be difficult to say. But maybe at 2-3 years, we may be able to essentially diagnose it. So sometimes it can be missed in the early stages.
Thank you. I have a question from the floor. One of the Lions is asking if my grandfather, my great grandfather, and my grandmother had glaucoma, and my dad does not have it. The person wants to know would I get it? I know you're not a psychic, but they want to know, I guess, their likelihood of getting glaucoma.
Right. So, I mean, it's all about risk stratification. The closer the generational link, the higher the risk. But nobody would dismiss your grandparents' risk being conferred to you. So, yes, I would say you should get checked. You should get checked. To say if you will get glaucoma or not, I can't say. But the important thing is to have the frequent eye examinations to ensure that if you do get glaucoma, you pick it up early enough that you keep your vision till you leave the earth.
Persons often ask how often they should get glaucoma checks. Is there a particular guideline? I know, depending on your situation, if you have a family history, if you're older, you probably should get it checked more often. But is there a number that person should generally say, well, a year, 2 years, 3 years?
Yeah, significant family history, definitely yearly after the age of 35 for sure. Some people will say 21, right? In our population. If you don't have a significant family history, usually it is every 2 years until the age of 60 and then yearly after that.
Thank you very much. If there are no questions at this moment, I would like to invite Dr. Dawn Grosvenor, who is our glaucoma specialist here in Barbados for many years, to give her remarks. The floor is open to you, Dr. Grosvenor.
Hello, good evening. Thank you, Alison. Good evening, Lions, Leos, colleagues, and friends. It is great to be in the audience for he's smiling at me, for Dr. Clark's lecture, because you've heard me say this so many times. It's great to be in the audience for Dr. Clark's lecture. And I think Dr. Goddard highlighted the commitment of Lions Division, and we have been working together, Lions and the ophthalmic community, for many years, and Lions has been a great support to us locally. And we do try to give back wherever we can, and that's part of this tradition of sharing the knowledge and giving these talks. Dr. Clark's lecture was very informative. As you can hear, he's a very knowledgeable ophthalmologist and a real people person, which you can hear coming through from the talk and the questions. And I found that this advice was really relevant, things that people could implement and apply to your life straight away. Helpful advice on when to start getting checked, how to use eye drops, how frequently to be checked depending on your age, and wonderful explanations on taking the eye drops, which is very practical for persons with glaucoma. I have been around for a little while and you've heard my voice quite a bit. So it's wonderful to have someone else in our community now who really is focused on glaucoma and glaucoma surgery, in addition to the rest of ophthalmology and cataract surgery as well. We have a very high prevalence of glaucoma in Barbados, and we really need all hands on deck. You heard from Lion Randy's story. Things have changed over the last decades, and it's really important that we keep up with those changes and those advances. And one of those things is making sure that we have another generation of specialists coming through all the time to improve on what we're doing. I always like listening to Dr. Clark and working with him, because I always feel that him being here now is a step up from what I have been doing and what I've been offering. Every generation should take us further than the generation before. And I think we're very fortunate to have another generation now taking us forward. So thanks, Dr. Clark, and thanks to you, Lions, for always partnering with us. And we're gonna keep this going. Thanks a lot, Alison.
Thank you so much, Dr. Pleasure having both of you here and having everybody here, in fact. Any questions? I know there must be some burning questions. Please don't be shy. Any questions? Dr. Clark, would you mind mind if you would stop sharing? I want to share something else on the screen, if you don't mind. As all of you know, we're hoping to have, not hoping to have, we're having a health fair, the Lions of Zone 3A, which is in Barbados. We're having a zone health fair, and I believe that is April the 6th. And more information will become available soon, and we will definitely share it with the public. And we hope that the persons here in Barbados will come out and support that health fair. There will be many things available, including eye checks, and of course, your normal blood pressure and blood sugar checks. So come out and support. Look out for more information for the Lions Zone Health Fair. Also, I would like to remind persons that we are having the Helen Keller essay competition. And that will be, the entries have to be in by the end of this month. The best essays will be moved forward for judging by our district governor, and the winners will win nice prizes. So we want to encourage the Lions to reach out to the community and have the young persons in the community to take part in this competition. Let me just share the flyer really quickly. So again, the topics of the essays are either a day in the life of a visually impaired person, or you can write on one cause of visual impairment, which could be glaucoma, which we learned so much about today. We want the young persons to do their research, and in doing the research, they will learn about visual impairment, and their parents and their families hopefully will learn, and it will raise awareness. And it will also help them with their writing skills, and they will get an opportunity to also speak. So they will get an opportunity for speaking. And of course, we like to have closer relationship with the young people. So this will be an opportunity for so much. So please don't miss out on this. Any questions you have, you can just email us at vision@subdistrict60b.org. I also want to shout out to my team, Lion Jillian Banfield, is the vision person for Region 3. We also have Lion Dion. She is responsible for Lion Region 4. She sent her excuses. She has another commitment today. And we also have Lion Kevin, who is responsible for Region 2. So any questions, you can reach out to any of those persons. I'll stop sharing the screen now. Are there any questions on anything? I think I saw a question in the chat. Yes, please.
Yeah, I was just going to read. There's a question in the chat.
You can go ahead.
Someone said that they were misdiagnosed with glaucoma and was told by another ophthalmologist that they would have to continue the medication even though they do not have glaucoma. Is this correct?
Glaucoma specialist?
All right, so nice. Yes, so misdiagnosed with glaucoma. I really can't comment on that person's specific personal issue because I've never examined them. I haven't seen them. But there are some cases where people don't have glaucoma and are on glaucoma medication. All right, sometimes we can have high pressures in the eye and not have glaucoma. And there are other potential complications of having high pressures in the eye other than glaucoma, such as getting blockages of veins in the back of the eye or even arteries in the back of the eye. So there may be many reasons why that person is still on glaucoma medication, but that's something they would have to discuss with their ophthalmologist.
Would you advocate getting a second opinion or third opinion?
I have tell every patient, if you feel comfortable, you should get a second opinion. There's nothing wrong with second opinions.
Thank you. Any other questions? Now is the time. We have our experts here. Let your questions rain. If there are no further questions, okay, somebody from Tricia, good evening to all. Excellent talk and presentation. Many thanks. If there are no further questions, I'd like to invite Leah Randy to give the vote of thanks.
Good evening, everyone. Lion District Governor Carlisle Goddard, and Alison Bishop Payne, many other distinguished guests on the panel and in the audience. Good evening again. I would like to thank, first of all, God for allowing us to come together in this manner and divulging such information that would help lots of persons understand glaucoma and how they can help themselves. Well, obviously there is no eradication, but to be able to treat it and live a long and healthy life, being able to see. I would then like also to thank Lion Denisa Belgrave for her prayer. Also, I would like to thank Alison Bishop Payne for the welcome. District Governor Lion Dr. Carlisle Goddard, PMJF. We would like to thank you for your remarks. Moving along, we would like also, especially even more than everybody else, because without the information shared here, we would probably not know as much. We would not know as much information. And you know, I'm so happy that he was here to share the information, because even persons like me that has been, you know, diagnosed with this thing and struggling with it for a long time, even I learned a lot from this presentation. So thank you, Dr. Clark. Also, we would like to thank the Dr. Dawn Grosvenor, my doctor. Very proud of her for her remarks. And I would advise anyone to go to Dr. Dawn Grosvenor as well, because she makes you feel very, very comfortable. Are you ready? So thank you again, Dr. Dawn Grosvenor. With that being said, I would like to also thank all the audience for being here, because without you, there would be no lecture to come to, right? So I hope that you will be able to take away that information from here and, you know, disperse it to all the ends of the earth, so that we will have less persons being diagnosed with advanced glaucoma like I was at 20 years old. So I thank you, the audience, for your attendance. Thank you, everyone. And back over to you, Alison.
Thank you so much, Leah Randy. Thank you so much, Leah Randy. We have a late question. Carlton Samuel, you can answer a question. You can unmute and answer a question.
Thank you. Thank you. I came in late, and I have a question. I've gone to the doctor a couple of times. I'm not seeing that clearly out of my right eye. But then when they tested it, they're saying they're not sure of what my condition is. But I'm just seeking some clarity and some guidance as it relates to, you know, if I use a glass, I can see far away clearly. But when I take the glass off, I can't see that clearly far away in the right eye.
All right, so Mr. Samuels, again, unfortunately, I have to give you the disclaimer. I haven't seen you, so I can't necessarily give you accurate information, but what you've been described sometimes can be associated with the age-related degeneration of the lens, or what we call cataract. As we get more and more cataract, we get more and more nearsighted, right? And what that can result in is that you needing glasses to see in the distance. With respect to your other eye exam, you probably need to just check your ophthalmologist and ask those same questions. and they may better be able to provide what is happening specifically for you.
Well, I'm concerned about the treatment. What kind of treatment you think would be appropriate for me?
That again, I can't really say because I've never actually examined you, unfortunately. So again, the ophthalmologist would best be able to go through that.
Okay.
You may have to come to Barbados and see one of our expert ophthalmologists.
You don't come to Jamaica at all? I'm from Jamaica.
Only on vacation.
I'd love to see you here. Oh, can I is this was arranged by Rotary Club?
Lions.
Lion Club, okay. Well, I'm the president for a Rotary Club in Jamaica, so I don't know if I can invite you down.
Yeah, welcome very much. We are happy to see the Rotarians with us. Thank you. Dr. Clark,
Okay.
you're being invited to Jamaica.
I would love to make the arrangement, necessary arrangement for you to visit with us and to highlight. I came in late, so I didn't get to hear enough. But if you appreciate, send me your email address or WhatsApp number, and I will pass on the information to my club, and we will make arrangement for you to come.
Sure, no problem. We'll pass on the information through Ms. Bishop.
Okay. So my contacts, you can get my contact, or you need to give for me to give it now.
You can post it in the chat.
Oh, okay. All right.
Okay, thank you.
I'll send you. I'll post my email in the chat.
Okay, thank you.
You're welcome.
I would also like to say thank you to Lion Wendy Labari for facilitating this session. Lion Wendy is a wonderful resource person in the district, and we don't know what we would do without her. So thank you so much to Lion Wendy. Somebody's asking if the recording will be made available. Yes, Lion Wendy will make it available on YouTube, so we can watch it again. And anybody who has any questions, they will be answered. Samuel, you would be able to watch the recording. So I will send you the recording. Just go ahead and put your information in the chat. I would also like to, you're welcome. I would also like to just say thank you again to Dr. Clark. Your presentation was very comprehensive, and as Lion Randy said, you made it understandable so that we can all appreciate and understand everything. And I especially like the frequently asked questions section. That was awesome. And people will always ask about marijuana and wonder, is it really effective? But I was hearing in the media just recently that they were saying whatever the benefits are, marijuana has a high correlation with heart disease. I think I got it right. So I don't know if the benefits outweigh the other factors. Maybe Dr. Carlisle could weigh in on that. But definitely it was an excellent lecture. So I would like to again just say thank you to everyone for taking the time out. I know it's a busy Saturday, and thank you for joining us. So have a good evening, everyone, and I hope that you will take this information out to your counterparts and so that they can learn from us. Thank you so much, and have a wonderful evening, and enjoy the rest of your weekend.
Good night.
Good night.
Thank you. Good night.
Good night.
I got your information, Mrs. Samuels. So I'll send you the link.
Yes, now that is my WhatsApp number at the bottom.
Okay. All right, great. And we will also, it should be available through subdistrict60b.org on YouTube as well, but I will send you the link. So thank you, everyone. Have a good night.
Okay.